My name is Spencer Green. I'm the current president of COPA, and I appreciate each of you joining us today. Today we have a webinar that will be hosted by Dr. Ken Kaufman. He is the principal investigator of the Limb Loss and Preservation Registry. This is a big picture idea in our field, something that will help to shape policy, will help to shape care, and ultimately should lead to better outcomes for amputees. So I think this has direct implications on what we are doing, and I look forward to figuring out how we can all become more involved. So Dr. Kaufman, the floor is yours.
Thank you, Spencer, and thank you to all for joining. I'll do a brief presentation. I'll show you some live aspects of the registry, and then most importantly, I'll answer questions. I think for efficiency, if you could put your questions in the chat box, and then we'll take care of them at the end. I'd like to answer 3 questions today: why, how, and what. Why is the registry important? How is it going to help you? And then what are we doing? This is a multi-stakeholder registry. Most registries are run by a single society, but this registry has many stakeholders that take care of the patients. And so that's a unique aspect of the registry, and we are sensitive to the needs of all stakeholders. Why do this? Well, first of all, there is no credible data about the number of amputees in the United States. The data that's always quoted is 2 million amputees, comes from projections from 2 states, and the data was collected in the 1990s. So there is no credible data about how many amputees there are, or are their characteristics, the incidence and prevalence of amputations. So the first thing is this is just going to get some important data, but more importantly, you're expected to support your decisions for providing care using evidence-based practice. And when there's audits, there's always the question of, are you providing the best care possible at the probably at the right price? And so there's not a lot of scientific evidence. There are always small studies, but there's nothing that's large scale, and much of it's anecdotal or not documented. So there's another also need for objective outcome data. So that gets into the how is this going to help? Well, we focus on 3 things. We focus on outcomes, we focus on the delivery of the service, and then because it's a national registry, health disparity. So things that affect outcomes are the type of operation that's done, the rehabilitation process itself, what components are they given, and then what's the cost of those components. Service delivery models will focus on the amputation level. Are there different models that work best for different amputation levels and different K levels? And then finally, health disparity looks at geographical variations, differences in social support, differences in the economics of the patients you treat. So that's how we're going to provide information. And so for evidence-based care, the reason that this will be useful is that you'll be able to go and use the data that's there to evaluate treatment options for that particular patient that's sitting in front of you. So if you can go in and you can say, well, the last 50 patients that look just like you, this particular approach seems to work best. That'll help you provide the best care possible to your patient and make their function as well as possible. In terms of service delivery, this will be important to set realistic goals. Probably one of the biggest thing with providing good patient care is that the patient has a realistic expectation of what they can accomplish if they've lost a limb. And then we do keep track of the visits, so it'll be possible to correlate patient outcome with the level of injury, their comorbidities, and their visit frequency. And finally, this should be a way to differentiate yourselves so that you provide consistent patient outcomes using the data above, And then you can compare how you're doing relative to other benchmarks. And this is particularly important because if you're treating patients with different levels of comorbidities, their outcomes could differ based on the fact that maybe they're sicker than another person treating people with less comorbidities. So that's how this data will be useful. So what are we doing? We're taking data from 3 sources: from the hospitals, from the prosthetists, and from the patients. These 3 sources are important. The data that does exist shows that for lower extremity amputees, only about 25 to 30% of the patients are receiving a prosthesis. That 25 to 30% comes from 3 different studies. There's a study we did at Mayo Clinic where we looked back 25 years and looked at the delivery of prostheses over those 25 years. There's a larger study that was done in the Veterans Administration with almost 10,000 veterans. And then there's a study that was done in Scotland, but they all came up with essentially the same numbers, that only about 25 to 30% of the lower extremity amputees actually receive a prosthesis. So that's why we needed hospital data, because if we only got data from the prosthetists themselves, we miss a large component of the patients that have amputations. And then we're going to get data from the patients themselves so that we can get their outcome data and not add any burden to the clinic. So the patients tell us they're willing to spend 20 minutes approximately, maybe 3 or 4 times a year, answering questions about their outcomes. So what we need from the prosthetist is simply the information on the care that you're providing. This data then enters the registry, and we will use that to create dashboards, to do analytics and write reports about findings about which method of care or which components are the best. There will be a possibility for de-identified research data, as well as data to help government agencies develop policies. The data comes in 4 flavors. First of all, there's the data from the hospitalization and the amputation itself. Second, from the provider regarding the prosthetic fitting. Third is the patient-reported outcomes. And then fourth is data that we hope to get in the future, which is objective functional outcome data from a wearable sensor. For the hospital data, we are getting information about the demographics of the patient, including their use of tobacco, their use of alcohol, and their educational level. Of course, the level and site of the amputation, where it was done, who was the provider, and most importantly, what are the payers? And then from the patient encounter, that is the visits themselves, we're collecting the codes, the diagnosis codes and the procedural codes associated with the amputation. Z codes are the social determinants of health. We're gathering information on the comorbidities and then the rehab services, specifically if they've seen an occupational or a physical therapist. And finally, a measure called the PROMIS physical function, which is a measure of their level of activity or mobility. So that's data from the hospital. From the providers, we are getting some similar data because we need to bring 2 different data sources together. So we're asking some questions about the person themselves to make sure that Jane Doe from the hospital is Jane Doe and you're seen in your office. And then we're asking questions about the type of components that they're getting. The patient-reported outcome data, first of all, is the information on mobility from validated questionnaires, socket comfort, and quality of life. And then finally, falls, which relates to safety. Now, this next data element is something that is coming onto the market supposedly later this year. These are wearable sensors that can be attached to the prosthesis or the orthosis itself. This sensor transmits data into the cloud, and so it gets data from the patient's activities in their free living environment. So this is real world evidence. And this is the kind of data that particularly the Food and Drug Administration is interested in having, because this is the objective data, how the patient is doing. For the prosthetists that decide to use this, there will be a dashboard. That dashboard shows the wear time by day and the step count by day. If you look at this graph, you see the first 4 days are basically in a blue-gray shade, and that's so that you get baseline data for the patient about their own activity and their own wear time. And then the following is the day-by-day estimate of the amount of time they wear the device, and then the number of steps. The lower graph shows a red, yellow, green configuration. Red is if they're 50% or less of their average data from their baseline. Yellow is 50 to 75% of baseline, and green is above 75% of baseline. This sensor collects data for 6 months. At the end, it's disposable. The battery needs to be recycled. And there are reimbursable codes to monitor this information, and then to say, bring the patient in if you see that there's a change in their activity level. So this is not out yet, but, and this is nothing I'm affiliated with, but it's something that I know about that will be coming. And I think this will be really useful for the prosthetist community. So the way this system is set up is you do not have to do anything other than what you typically do in your clinical environment. So you meet with the patient. There will be a need to sign a participation agreement, which I will talk about at the end. Once the participation agreement is signed, we're working with your EHR vendors to transfer that data to the registry, and then the data can be analyzed in the registry and output to dashboards that you would have available to yourselves. So each prosthetist, after signing a participation agreement, will have a secure, I'll use the term bucket, to put the data in, and then that data is brought into the registry. So there's nothing in your electronic system. You're pushing the data out, and then it's being pulled into the registry. And this is all done under a very secure file transfer protocol. And we had to meet the very stringent security requirements for the federal government so that we can hold the DOD and VA data. So I tell people that this is more secure than the place you're holding the data right now. This is a little bit about the current data in the registry. There's about 36,000 patients. I'm showing them by DME MAC jurisdiction here. The average age is about 70. We go from childhood to some people over age 100. Right now, we only have data from the lower extremity. So it shows, of course, toes and partial feet are the most predominant percentage of patients, but we have a pretty good amount of transtibial and transfemoral amputees as well. We are in the process of adding upper extremity patients, but that is not something that I can show you yet, but that will be forthcoming. We have about 8 million visits in the registry, and there's about 200,000 visits a month. This would be visits to either inpatient or outpatient hospital facilities. As I said, we're collecting information on the comorbidities of the patient. So this graph shows the percent of, or the number of comorbidities that the patients have. So there's only about 2.5% of the patients that have no comorbidities, and the average number of comorbidities for these patients is about 8, and you can see the distribution from 0 to 21. The most common comorbidity is peripheral vascular disorders, followed by cardiac issues, followed by renal issues and vascular disease. And then there's diabetes, both uncomplicated and complicated. So this shows the percentage of patients that have these particular issues, and about 22% have peripheral vascular disorders. This graph is showing the discharge location. About 96% of the patients are discharged to the home after being in the hospital. If we take a look at that 5% that are not discharged to home, most commonly they either go to acute care hospital or skilled nursing facility. This graph will tell us something about the PROMIS physical function, which is a measure that was developed by the National Institutes of Health. In this particular measure, the general population has a score of 50. And then there is patients on both sides of 50 in the general population. The way this is set up, the data is standardized. So if you go from a 50 to 60 or a 50 to 40, that's one standard deviation above or below normal. And so high scores are better and low scores are less function. So about 80% of the population has a score of 40 or higher, and about 20% has a population score of 40 or less. And so you can see if you go down to a 30, you have a moderate loss of physical function, and if you go down to 20, you have a severe loss of physical function. Well, this is the data for the patients in the registry. We have data on about 10,000 patients. And actually, this is a little bit dated. I just looked. The average score is about 40 for all the patients in the registry. And to benchmark that, patients that are going to have a joint replacement have a score of about 39, as do patients with rheumatoid arthritis. And patients who have are candidates for a heart transplant have a score of about 25. So that puts the patients with lower extremity amputations in context. Their mobility impairment is about the same as patients with arthritis or heart disease. And I think this is a real important slide, because this allows you to talk to insurance providers and give a context for the mobility loss that your patients have relative to other large populations of patients that exist in the United States. This data is data for the Z code. These are the social determinants of health. So of the patients that completed this, the number one problem they have is related to housing and economic circumstances. Next is relationships to the social environment, and then other issues with family circumstances. So again, these factors will affect the outcomes of the patients, and so that's why we're collecting it. We are collecting information on the payers. As you know, for this population, which has an average of about 70, the largest payer is Medicare, Medicaid. And the second is either commercial or private insurance. And then for secondary payers, that's just reversed. We're going to work on refining this a little to get a little bit more granularity on the payers, because I think that will also be important to look at the payers and the outcomes that patients are receiving, probably based on the components that they're receiving. And this is an interesting fact as well. This is the therapy visits. About half had therapy visits and about half did not. And of the people that had therapy visits, the average, the most common was 2 to 5 therapy visits. So this was either seeing a physical therapist or an occupational therapist. So I'm going to stop sharing here for a second, or just jump out of this and try and show you. So this is the actual registry itself. So these graphs should be familiar to you because there are some that I just showed you, but I want to show you some of the features of the registry. So these were the comorbidities that I showed you, and these are all the amputation levels. So we can change this. We can say, well, let's look at the comorbidities just for transfemoral amputees, and then it'll repopulate with the percentage of patients that have the comorbidities that are shown. The order is still the same, but you can see here that transfemoral amputees have more fluid and electrolyte disorders than the general population. This is the graph on the number of comorbidities. And again, that's all patients in the registry. Remember that we have a lot of patients that have either toe or partial foot. So if I take those out, you can see that it shifts because of the dominance of partial feet and toe amputations in the registry. So this allows us to look at the data, and if we're interested, we can actually see the actual numbers. I'm going to go to the promise measure. Recall that I said this is a real good indicator of how does these patients function compared to other general patients like arthritis or hip or heart disease. So the average for all the patients is 39. If we look at just the transfemorals, the average there is 35. So you can see more mobility loss with the transfemorals, which makes sense. And if we just go down to partial foot, you can see how this has shifted and the average is now 40. And the final thing I'll show you is the Z codes. So this was the graph that I showed you previously about their social determinants of health. I think the other things, this in case of this payers, we've broken that down by jurisdictions. You're in jurisdiction D, is that correct?
That is correct.
So this would show the distribution of payers in jurisdiction D. So so that gives you an idea of what the registry can do in a dynamic sense. So let me just go back to this. So this data is real world data. It's not cherry picking 10 or 20 patients, but this is all patients. This is important because it accounts for the complexities of clinical practice and the chaos of clinical practice. This data is useful for improving the quality of care, developing guidelines, providing research, which will then guide national policy. The registry is set up so you're not needing to do any additional work to participate. We are working with the O&P EHR vendors to get the data that we require. It does require that a participation agreement be signed. I've provided that participation agreement so it could be distributed to all of you. When you sign at this point, there is no cost because at this point, the registry is being paid for by federal funds. There will be a point in the future where there will be a subscription fee. But right now, we're just trying to get as much data as possible. So the more data we have, the more impact this has. As I said, we've worked with your O&P EHR vendors so that the data can be passed to the registry. That is work in progress. We are, hoping to have the data flowing over the next 2 or 3 months, but it's currently a work in progress. And another reason to have you join is we are interested in hearing from you about what dashboards will be of use to you. So the information about the registry can be found at the URL llpregistry.org. So I encourage you to take a look. And with that, I thank you, and I'm happy to answer any questions that there may be.
Great. Thank you, Ken. Fascinating information. I think that we would all agree that the field of orthotics and prosthetics has been void of solid data and enough data to really use to reshape clinical practice guidelines and certainly policy. So thank you for leading this effort. So just so everyone knows, in the chat is the participation agreement. I'd just like to kick off with a quick question about the agreement. Is this signed at the facility level or the individual level, the individual clinician level?
Yeah, it would be signed at the facility level. So if you mean the organization level, is that what I'm understanding?
Right.
Yeah.
Right.
So we need somebody from your organization to sign that. And it explains the how the data is going to be used, how it's protected, the indemnification in case there's any security breach. It provides all the answers that I think you might have with regard to how this is going to go about.
Great. There's a question in the chat that says, what is the mechanism for researchers to access this data?
Yes, that's a good question. Researchers will need to provide a protocol. This is a quality improvement registry, meaning that we're using the data to improve the quality of clinical care. So if there's going to be research that's done, then there will need to be consenting of the participants for the research to occur.
So currently that's the only question in the chat box. I would encourage the group to come off mute and ask your question if you have one. Is there an assumption or some reasoning behind why only 25 to 30% of amputees receive a prosthesis? It seems a lot lower than I would expect.
Everybody feels that way. There's a question of why is it that way, and why can't we get that up to at least 50%? That's why the registry is being formed, to answer questions like that.
Yeah, great.
Hi, my name's Anna Vergan. I'm a pediatric orthopedist at UNC. Can you hear me?
I can.
Yeah.
Okay. I thank you for putting this together. I'm really excited to see this, and I see some of our ACPOC members here, like Colleen Coulter and Hugh Watts is on. And anyway, that's we're all excited because the registry has been a long time coming. For speaking from the PEDS side of things, is there a way, and forgive me because I did come on late and you may have already talked about this, but for congenital malformations and things that are a little bit not quite as straightforward as above knee, below knee, through knee, like, you know, the PF.D. kids with Turner, like a rotation plasty, is there a way that we can keep track of their anatomic differences that aren't, like, you know, obviously fit into little neatly into boxes here?
Yes, we are getting people of all ages from you know, birth to mortality. The one thing I'm finding is there are no clear-cut, for example, rotation plastic, there's no clear-cut codes. So what I need from you or your colleagues is either the CPT or the ICD-10 codes relative to you know, disorders of interest to you, so that we can add those codes. So right now we're trying to pull, you know, information of interest, but if there's codes we're missing, of course we won't have that. So I mean, my request to you is if you can provide me some codes, we can cross-check with the codes we're currently using, And if there's codes that, we should add, we're happy to do so.
Okay, and they can have more than one code. Like, let's say they were born with like a fibular deficiency, but then was converted to like a SIME or a Boyd amputation that basically functionally they're a BK at that point. And you'd want to keep track of both those things. Would that be something feasible within the database?
Yes, and that's a good point. So once the trigger code is hit, i.e. an amputation or a limb preservation, or in the case of congenital, a congenital code is triggered, then they're followed longitudinally. So we can get data as they're, as the level of amputation goes up, from toes to SIME, that kind of thing. So that's why, we've got about 200,000 visits a month, because we're following them longitudinally.
Hey, Ken, this is Maynard. Is the frequency of being fit with a prosthesis influenced by the level of amputation? You indicated the preponderance in the data are toes and partial feet, which is understandable. Is it related to that in the denominator, or can you tell?
I'm formulating my answer. Ask me the question again.
Well, the frequency of being fit with a prosthesis of being 25 or 30%, is that, I think everybody's trying to understand why such a low level, right? And I know this data has been emerging over time, indicating, last I saw it was something like 50%, and even that was kind of shocking. But is it down as low as, say, 25 or 30 because there's partial foot inclusion or something of that nature that would influence the data?
Yeah, so a couple of points to your question, and good to see you, Maynard. First of all, the study we did was just transfemoral amputees. So those are high-level amputees. The reasons that they were not being fit, and bear in mind, this was a small group of 100-some patients, was they were not really active before the amputation, so they had either a lot of more morbidity, or mortality was another reason. I can't speak to the 10,000 patients in the VA, but that's a much larger data set. But to take this a step farther, at least the hospital data that we're seeing so far, we can also pull in prescription data. So we can look at, of the patients who had an amputation, how many patients actually get a prescription for a prosthesis. We're still working on getting the data from the prosthetists EHRs, but I'm hoping that we'll get data from how many patients did a prosthesis see and how many patients in the prosthesis actually fit the prosthesis. So if you kind of go down the stream, they had an amputation, did they get a prescription? Did they see a prosthesis, prosthetist, or did they make a prosthesis in their garage? And then when the prosthetist saw them, was the decision that they should actually get a prosthetic component. So that kind of gets the whole picture. And I'm hoping that we can catch all that. Like I said, from the hospital data I've seen thus far, I think we can answer how many actually got a prescription.
Okay, very good. Thank you.
I see a hand up. Colleen, do you have a question?
Yeah, Dr. Kaufman, I heard you twice at the Amputee Coalition. I don't know if you can hear me. This was a couple of years ago when we were in person. And again, like what Dr. Bogone said, talking about children. At that time, you were not prepared to look at kids. What are the age, what are the parameters for data collecting on this?
I didn't hear the last part, Colleen, I'm sorry.
Yeah, what are the parameters? Like what ages are you looking at? Are you looking at newborn all the way up, or I think you mentioned a cutoff like, mid-teen was what you were looking at.
Thank you for that question, Colleen. We're taking all ages from newborn on up. The trick is to make sure that we've got the right codes so that we're getting the patients that you might be interested in. So, if you say, well, I'm interested in a particular type of patient, we just have to make sure that we're got the right codes in the database that we're pulling.
Because I studied a list and I have to find the list after we met. It's all like I ended up with 3 pages so far of P codes that are the congenital codes that we even started. So I will try to unearth that and get it to you somehow.
Yeah, please. And I've got a list of codes, but I find that the more that we can work together, it doesn't take any more effort to pull the once we have the codes, that's an automatic trigger. So it doesn't take more effort to double the number of codes. It just makes sure that we're getting what we need.
Any other questions from the group?
I don't know, Dr. Kaufman, I know this is a little bit aside, but with Dr. Verdone and Dr. Scott Ward on the phone, we have ACPOC has an annual conference coming up in Minnesota, in Minneapolis, and it's in May this year. And this would be fabulous to present to the ACPOC members. Don't you think, Anna? To capture some of the pediatric information.
So the quality of the data we're going to get is going to be dependent upon hospital participation. The same agreement applies to hospitals participating. But if you can encourage the hospital that you're affiliated with to participate, that's the best thing possible for us.
Okay. Well, I think we're all familiar with the phrase that there's power in numbers, and that certainly applies to data collection and the quality of the results that come from analysis and the way it makes its way back to the field for improved treatments and certainly improved patient outcomes. Are there any other questions, Dr. Kaufman?
Well, Spencer, I really appreciate the opportunity to present to this group. And if there are questions, please reach out and I'll be happy to answer them.
Thank you very much. And thank you all for joining. Appreciate
Okay.
your time today.
Bye-bye.
Thanks again, Sly.
All right. Bye-bye.